faculties, those who have come in time and would like to share their experience. This is a very important topic. IOL, you put the IOL after so many, hard work, using a lot of formulas, this, that, and then at the end, next day when you find that the IOL is not in place. So now what? It is either on the first day when you find that there is not in place, or maybe in the immediate post-operative period. But the situation, let me tell you, it's very, very scary for the surgeon, and particularly for the one who has operated this case. So, and at that time, if you don't help this patient carefully and mildly, politely, there are all chances of patient going to the other surgeon. And this now, when you see these patients, then IOL can be in the anterior chamber, can be just decentered, or can be subluxated or dislocated. Now to how to handle this situation. And I'm very happy to tell you that we have excellent galaxy of speakers. Those will cover different issues regarding this challenge. We have Dr. Urvija Chaudhary. She will cover, when you see the patient, how to counsel. That's very important. And then, if the lens is loose, dislocated anteriorly, and then we have Dr. Harbans Lal. He must be on the way. He has not reached yet. So he will take how to handle that situation. And then we have Dr. Shail Vasavada, very eminent surgeon from Ahmedabad, internationally reputed. And he will handle how to handle this decentered IOL. And then I will share my experience and views how to handle the subluxation of IOL. And then we have, suppose the lens has gone into the vitreous, and then we have Dr. Vineet Shah, VR surgeon, how to bring it back to the normal position. And the most important, we have Dr. Rajiv Chaudhary, again very eminent faculty surgeon from Indore. He will give us the tips how to avoid this situation during the primary surgery. And if the complication occurs, any complications, then still how can you place the IOL? So with this, we begin the party. And we go to the Urvija, please.
Thank you, sir. Good morning, everyone. Thank you for this opportunity. Counseling in a case of complicated cases where IOL dislocation, it's very important. And there may be many such conditions in your daily practice which may need few extra minutes of your chair time. So like conditions like trauma, posterior polar cataracts, zonular weaknesses, pseudoexfoliations, posterior capsular ruptures, and even the slightest of the IOL dislocation or the tilt may induce higher order aberrations, which this can be identified on the aberrometry very clearly, where it demarcates that the problem is not in the cornea, it's in the internal area, that is the lenticular part, which is causing all the blurry double vision, glare, halos. This was one such case which came with a 6/6 vision with a -2 cylinder and was showing a whole lot of blurry vision, glare, halos problem. On aberrometry, we identified it to be an internal error. It looked centered, but it was just tilted. So here, when you counsel the patient, when you talk to them, it enables them to understand that what is their situation, how they can plan their treatment. It helps them, it empowers them to take better informed decisions for themselves. And at the same time, it will help them set very realistic expectations about the outcome, about the recovery period, what are the potential risks. And talking to the patient will definitely foster trust between the doctor and the patient. So talking, counseling them before any such complicated situation is very, very important. This also increases the compliance of the patient to your treatment. When you counsel such patients, your approach should be very empathetic. You should listen to them very actively, answer their all questions, validate their concerns, and keep reassuring them about all the concerns that they present to you. And that builds a very good environment between the doctor and the patient. You have to explain to them the condition, the causes, what are the treatment options for them. And for this counseling, you better can use the help of visual aids, like understanding them, the anatomy, how the things happened, where is the problem. And you can give them literature, written materials, which will help them understand and take the decision. When you discuss the treatment options for them, it can be either conservative treatment if the symptoms are very minimal and the visual acuity is preserved, and you can just keep them on regular follow-ups and ask them to keep following with you. In case the problems increase, then it may require surgical option. In surgical options, you can plan a IOL repositioning if the IOL is not very much dislocated, and you can just correct the position of it. But in certain cases, you also need IOL exchange. So you need to explain them that was the problem, where is the problem, there was this capsular defects, and we need to, this IOL will not work for them, and we need to either change it to 3-piece IOLs, iris fixated IOLs, or the scleral fixated ones. This was very interesting case. Sometimes the IOL gets decentered so minimally, which I just showed back. It was very minimally decentered. It was not being identified on the slit lamp that where the problem lied. So here the aberrometry helped him. When we checked on the eye tracy, there was a clear demarcation that cornea abrasions were very minimal on the lower map, and the main abrasions were on the internal map. Internal map shows the lenticular part mainly. So the abrasions lie there, and eye tracy has got a very nice toric assessment plan, which showed that if you see on the toric data, the corneal power is just 0.75. So there is no astigmatism on the cornea. Therefore, the toric was not planned for the patient. It was a simple monofocal lens plan, and the patient was accepting a -2, 2.5 cylinder something. And on the toric lens power, you could see that it is showing a 2 cylinder. So once it is a monofocal lens, how it is showing a 2 cylinder? So there we identified that it is a tilt and not the decentration. So, and the IOL was rotated, capsular fibrosis was relieved, and he was doing very fine. So you have to explain them the risk about infection, all the retinal detachments, glaucoma, corneal edema, repeated dislocation in the future. There can be some residual correction, astigmatism, and the recovery may take a little long. But at the same time, also empower them, tell them the benefit of the repeat procedure, that it will increase the visual acuity, it will reduce their symptoms, it will overall increase their quality of life. So patient education about all the post-operative care, recovery time, the restricted activity period, follow-ups has to be told to them. And intraocular lens decoration can be challenging condition for the patients, but effective counseling can definitely help them alleviate their anxiety and guide the decision making. And by providing a clear information, empathetic support, discussing the treatment options, the doctors can empower their patients and help them make informed choices. Thank you.
Thank you.
Thank you, sir.
Yes, very true. Yes. Very true. Very true. Yes, yes, very, very true. You very rightly say that we must avoid certain words. That is very, very important. So anyway, thank you, Vijay.
Thank you, sir.
We go to the next presentation, but I am afraid Dr. Lal has not come. Subrata, have you contacted Dr. Lal? Where is he? Is he on the way? Okay. So we go next, Dr. Shail Vasavada. He will teach us how to manage decentered IOL.
So thank you very much, sir, for first of all conducting this course every year and making us a part of this wonderful, wonderful teaching course. We do receive research grant support from Alcon Laboratories. So this was a 54-year-old female complaining of decreased vision in her right eye for the past 1 month. And looking at her past history, she's had multiple recurrent episodes of pain, redness, and sudden worsening or blurring of the vision in the last 3 months. When we looked at what she's using, she was on Nepafenec eye drops 3 times a day and a combination anti-glaucoma drop 2 times a day, with intermittent pulses of topical steroids being given over the last 3 to 4 months. Looking at her other history, she's had undergone cataract surgery in her right eye before 4 months. Her uncorrected visual acuity is, counting fingers, 3 meters, but the good part is her best corrected visual acuity is 6 by 6. She has a significant myopic error, spherical left behind, along with a significant astigmatism left behind. When we actually looked at the photo slit, when you look at the cornea in without making a slit or anything, it looks quite okay. Nice cornea, round pupil, no iris chafing, no peaking of the pupil. The only thing you can notice are few atrophic iris patches and some pigments on the IOL. However, when we actually made a slit and looked for it, the chamber looked very shallow, and it looked shallow irregularly. So if you look at it, the superior anterior chamber is deep, whereas the inferior anterior chamber is practically, there is no anterior chamber. The iris is almost coming and touching the corneal endothelium, which means that there is some asymmetry some ways in the IOL positioning. Now, after dilatation, we were expecting that probably there must have been some capsule rupture somewhere, and maybe that may have led to a decentered or something of the IOL. Surprisingly, the entire posterior capsule is absolutely intact. There is already presence of Elschnig pearls developing. The only positive or something that we found amiss was that there is no anterior capsule rim seen anywhere, even after about 7 millimeters of pupil dilatation. So we decided to investigate it further and look for what's going on behind the iris. And on doing a UBM, what we found was that the IOL is not only, first of all, in the sulcus, but significantly tilted. So if you can see, this is the haptic on the iris on this side, on the capsular zonular complex on this side, and here the IOL optic as well as the haptic are going and pushing the iris up to the corneal endothelium. Once again, the good part was that the posterior capsule seems to be intact all through, and we did the scan all across 360 degrees. We felt maybe there may be some peripheral equatorial PCR which may be there, but at least the UBM did not show anything very grossly wrong. So now we have a situation of a single piece IOL in the sulcus with asymmetric fixation. Posterior capsule is intact and no anterior capsular rim is seen. If we leave this patient this is like how it is, there are very high chances that she will constantly go into a uveitis glaucoma hyphema syndrome, and sooner or later it will start getting worse from bad to worse. So we had to do something about it. What were the treatment options that were there in front of us? One was just explant this single piece IOL and just put a 3-piece IOL as it is. Wherever that may be, even if it ends up in the sulcus, maybe the 3-piece may end up being slightly safer. But we weren't sure why this single piece IOL is behaving so awkwardly or is getting pushed forward so much. Was there anything to do with the iridociliary body zonular complex? And intraoperatively, after trying to dissect, and if there is fibrosis or if we end up with a PCR or a zonular dehiscence, we need to be also prepared for the possibility of some form of scleral fixation of the IOL. So we kept all the options in mind, and therefore I made a slightly scleral incision. We have taken up the patient for peribulbar anesthesia, and the first thing that I inject is dispersive viscoelastic, because I know the endothelium is going to get a little more affected during these maneuvers. And you can notice all of these pigments, these are all iris pigments released and stuck on the IOL anterior surface. So I'm injecting a generous amount of dispersive viscoelastic, and then I'm trying to just see if the haptic-optic junctions are free. And fortunately, this optic-haptic junction was quite free and got dialed out nicely into the anterior chamber. The inferior one, I did struggle a little bit, but it wasn't very bad. There wasn't too much of fibrosis, and probably because this being a hydrophilic IOL, the fibrosis doesn't occur as quickly or as aggressively as a hydrophobic IOL. Now I could have made a smaller incision and cut this IOL and brought it out, but hydrophilics are typically quite difficult to cut, and also there was significant shallowing of the anterior chamber. So here I was not too much concerned about what some little more astigmatism that I may be inducing, and therefore I just removed the single piece hydrophilic IOL in one piece. Now what I'm trying to do is I'm trying to look and stretch the pupil and see if I can see something, either the anterior capsular rim or the, any equatorial PCR that there may be there. And fortunately, or the good part was, there's no gross PCR or anything seen, but there's no anterior capsule rim per se, which I could see, which I can open up and try and use that as a support to place the IOL inside the bag. The only place where I noticed was this area, where I felt there was an anterior capsule rim which was fused completely with the posterior capsule. But rest of the almost 200 degrees area, I could not find anything which I can use to make sure that I can place the IOL in the bag. So now I'm operating them for the second time. So I want to make sure that we don't have to operate them again. So having some experience with traumatic cataracts and pediatric cataracts with optic capture, we decided that although the patient has an intact posterior capsule, we'll try and do a posterior capsulorhexis. And after having created a nick, I'm actually injecting cohesive viscoelastic through the puncture, which will make sure that the burger space is filled up with viscoelastic. So there are very minimal chances of catching any vitreous while doing the PCCC. So I'm trying to perform a PCCC. Now for optic capture, I need a decent size PCCC, which I could not achieve in the first go. So I'm trying to enlarge now this PCCC in all the 360 degrees direction, because I need at least a 4 millimeter PCCC through which I can buttonhole the optic through the PCCC. So once again enlarged it on one side, and now using these Greischeber scissors to initiate a nick so that I can convert it from the other side as well and make it into a decent size posterior capsulorhexis. And here I think the role of good cohesive viscoelastics, Helon GV or Helon Phi, no financial interest, and micro incision rhexis forceps go a long way. So now we have a sulcus support along with a posterior capsulorhexis of a decent size all around, and therefore now the plan is to probably do a 3-piece IOL with the haptics in the bag or sulcus, whatever that space is, and then try and buttonhole this optic through the posterior capsulorhexis. So after having just placed the IOL just like that without any injector, as the incision was decently long, I'm making sure that first the haptics go in the sulcus or in the capsular bag, and once that has been achieved, now the time is come to push this optic through the PCCC. So bring the optic, pull the optic to the center, and then just push it through the posterior capsulorhexis, and that will make sure that this IOL, so I'm pulling the optic to the center, and once having done that, pushing it behind the posterior capsulorhexis. And once you see this kind of appearance on the posterior capsule, that's a sign that the capture has been done perfectly. So once again, pulling the optic to the center and creating the optic capture. So now this IOL is not going to move. It's going to stay in its place. It's not going to come forward, and it's not going to cause any uveitis, glaucoma, hyphema. Always make sure in the end that there is no vitreous disturbance that has occurred. So injecting diluted triamcinolone, and fortunately there wasn't anything. This is how the patient looked at 1 week, and you can notice uniform deepening of the anterior chamber. Fortunately, the patient did not have any episodes of uveitis, glaucoma, hyphema, and refraction wise also, surprisingly she did well, although this was not something that I expected. And post-operatively, there is an area of synechia that is developed, but that's a very small consequence of the situation that we had. And this is 1 year follow-up. Notice the well-centered IOL, and this patient will never have a PCO because of the optic capture. So single piece IOL is not meant for the sulcus. Use intraoperatively if you find your rhexis is compromised. Please go ahead and do a primary 3-piece IOL. probably if a primary 3-piece IOL was done, this would never have occurred. And I think posterior optic capture is a good option to consider in certain special situations. So thank you so much for the patient listening.
Thank you very much. I have a question.
Yes.
Was it your case or somebody else's case?
No, sir, it was someone else's case.
Okay, fine. Number one, sorry. And number two, what you found probably, as I understand, that there was a adhesion between the anterior and the posterior capsule in the lower part.
Yes,
so
sir.
that must have pushed the lower haptic outside, and that was pushing anterior.
So I think, sir, what might have occurred was that maybe it was a relatively youngish patient, and the rexes may have become too large.
Yeah.
And I could find the fusion only in one quadrant. I couldn't actually find any fusion or any rexes in any other quadrant. So I just haptic junction, and therefore the single piece IOL in the sulcus is lethal. If not today, it will show up tomorrow.
And I would differ.
Yes, sir.
See, you lot of
Intraoperatively, I couldn't actually find any place where there was an opening where the IOL haptic could have been there, and it sort of rotated out very easily without anything. So, yeah.
from the friends, anybody has any experience regarding management of the anterior dislocation? Anybody would like to share? Okay, thank you,
Thank
Shail.
you, sir. Thank you.
We don't have Dr. Lal. Let me go. So when the IOL is not in place and it is subluxated, then what I would do in my hands, let us understand it's a very scary situation. Then it could have led to, because of the intraoperative complications, it might have happened, but not managed properly, like PCR, and then vitreous prolapse in the anterior chamber, or there might have produced any zonular dehiscence. Or after this, all these, the IOL probably was not placed properly. Sometimes what I have seen happens even with uneventful surgery, particularly when you have selected a very small size IOL compared to the overall eyeball size and trauma sustained at home. Now to reposit same subluxated IOL in position, or suppose there are some lenses you cannot refix. There you have to exchange with a well-fixated IOL at earliest with minimum maneuveration. Now, what are points we should consider? First of all, we must assess the situation and the cause. To assess posterior capsular support availability and the type of IOL used, particularly when it is operated by somebody else. What are the options? There are some lenses which you can use the same lens to see here in the on the screen. You can reposit the same lens in the. Welcome, Dr. Lal. We welcome you all. So I have taken your place. So you, okay, thank you. So to use the same lens to reposit in the sulcus or to fix it to the sclera. Or there are lenses where you cannot refix. You have to exchange, take out the lens and put a new lens in the sulcus. Now these lenses, some lenses need to be expanded, like Bausch & Lomb mill lenses or Zeid lenses. Their design is such, you cannot refix with the sclera. Now this is grossly decentered subluxated IOL, you can see that. The good part is that you can see the rim, the rexis. The lens has been brought into the anterior chamber first, but this is very important. It must have been replaced. There must be some reason. So what I usually do, I do vitrectomy and make sure that the area is free of vitreous. Everything is cleared, and then Once it is done, I usually use the anterior chamber maintainer, because at this time, no, there is a push because of the pars plana. Already you put the pars plana infusion cannula, so that will push your vitreous anteriorly. So I stop it and then use the anterior chamber maintainer. Once it is all set, gradually, gently dial the lens in the sulcus. Now, I have a long-term experience of these lenses, and only thing, let me tell you, why we don't do this, as I understand, because there is a chance of CME. But if you do the vitrectomy well, and if you go not up to the macula, but I mean subtotal, then I think Vinith would agree that there are very less chances of CME, and of course, iris pigment dispersion. It was easy, no? Minimum maneuveration. Then there is another case where it is a thin, rigid IOL. You can see that. This is what you see. This side is a capsule, and the other side, there is no capsule. I mean, the posterior capsule. There is a charity case, the 3-piece IOL, rigid. You can see that. Now it is, we try to figure it out, what has gone wrong and what we should do. But then it was difficult because there was no support on your left side, right side, sorry. So in that case, we must make sure that there is enough support and the lens is placed very well. But then I thought that to put the lens in the sulcus would be difficult. So I thought there is enough support, posterior capsule support on one side. So I thought, why not to fix the only one haptic to the sclera? And this is what I did. After making the triangular flap, through the small sclerotomy incision, that loop, you can see that the loop is brought out, it is sutured, and then it is pushed back into the eye. The wound is closed. So this side of the haptic is fixed to the sclera. And this here is very, very adequate posterior capsular support. So this is, and I have a very good follow-up, long-term follow-up. It's very excellent. Patient is doing very well. Then there are situations where the lens has subluxated into the anterior vitreous. Not it has gone, but in that case, the same lens what we have fixed to the sclera, same lens. The lens has to be, must do the vitrectomy. Dr. Vinith Shah will cover it better than me, how to handle this situation. But then the lens haptics, it is being caught on one side. You have to see the position of the lens, make sure that it is properly brought into the, ultimately it is to be put into situation. We make the triangular flaps on either side first, and then through the sclerotomy incision, the haptic is brought out. We use 8-0 ethylone suture, non-absorbable, and it's very well fixed to the sclera. And by the time there is adhesions around the haptics, so even if the suture disintegrate after some time, the loops on the haptics, they don't become loose. And we have a very long-term follow-up in such situations, such cases, and they go very well. So this is how the one haptic is fixed. And then the second haptic is brought out, the other side. Now you have to make sure that these are exactly opposite. Otherwise you will have a lot of astigmatism. At this point of time, the chamber is very well maintained. Here, it's very, very important that your maneuveration should be very, very gentle. Suppose at times, suppose you break the haptics, you have to explant the lens and put another one. This has happened with me too at times. Very rarely, but that it does happen. So again, both the haptics are very well sutured and placed inside the eyeball. So this is intraocular. The haptics are going intraocular, not on the sclera, and you can see the last scene. This is, I think I will skip this video. So this is how you have to handle, you have to manage the subluxated IOL. If it is better, if it is handled by a vitreoretinal surgeon or an anterior segment surgeon with a standby VR surgeon. Or if you have exposure, you are exposed to the vitrectomy. This vitrectomy is must in these cases. So you can manage very well. Thank you very much. Any questions from the audience? Anybody from the panel? Sir?
Insignificant descentation occurs quite often in 25% of the cases, but clinically significant descentation occurs only in 3% of the cases. And most of the time, the presenting complaints are photopsia, glare and halos, post images, double images, photosensitivity, and there may be some related to the blurring of the vision, and the loss of contrast is one of the commonest thing. So this is a patient who had a pseudophakic patient, operated 8 years ago, maybe now more than that. And this was the picture. It was operated by me. At that time, foldable lenses were not so popular. The patient had pupillary capture. And after 8 years of the pupillary capture, also you can separate the bag. I can actually redial the lens. So I have seen that the separation of bag is possible irrespective of the time frame. And recently, so we put on a Hilon GV, and then anterior and posterior capsule were separated. And there was actually anterior capsulorhexis margin runoff at the time of surgery. That was the region of descentation. So you can put this lens back into the bag, but sometimes where the lens loop is there may be adhesions may be too strong, and you may not find enough of a space. And if you feel that the bag is not well centered when you place into the bag, then you can actually put into the sulcus, because this was quite a big lens. So there was no problem in placing this into the sulcus. So we tried to place into the bag, and once we found that probably may not center well over there, you can place into the sulcus. And then you constrict the pupil after putting the lens. So after putting into the bag, I was not very comfortable. So taken it out of the bag and placed into the sulcus. So now, in fact, you can dial the lens itself into the bag. And initially we were scared. Just recently I operated a child, nearly 10 years old, and the toric multifocal lens was placed. And after 4 weeks itself, there was a strong fibrosis. But once I went in, I found I can remove whole of the fibrous band comfortably without any problem and reposition the lens. So it is possible to remove this fibrous band as well. And posterior capsule is not as weak as we think it is. So this is another patient. This was one-eyed patient, had a high myopia, and lens was subluxated down. And you can see the loop is somewhere coming out. So I didn't want to do the complete surgery. I thought, okay, it's a one-eyed patient. Why to do the massive surgery of doing vitrectomy and taking it out and place it again? So at that, just I put on one thread, one needle above the loop, one below the loop, and pulled it and fixed it onto the sclera. That served the purpose for the time being. If the other loop dislocates, then we will do the second surgery. This is a young boy, approximately 26, 27 years of age, operated congenital cataract, had a controlled glaucoma borderline, and the pressure was 22, 23 with the maximum medication. And there was a lens was into the anterior chamber, one loop behind, one in the front. So we thought we'll remove this lens first before doing any surgery for glaucoma. So we took it out. Whenever I want to take out the loop, I usually put one instrument below, one above, and pull it out so that it is guided well into the incision. So whenever you want to cut and remove the lens, so this lens was taken out, and then a standard scleral fixation of the new lens was planned. So after tying I used Prolene 90 sutures. So there were double arm, 2 Prolene 9 sutures were used in this patient. So both the sides, 2 needles were there. So we pulled out 1 needle. Same way, all the 4 needles were taken out. Initially, I used to put on a cross and then take it out and then tie the thread. So I found that tying the thread without needle takes a little longer, a little more cumbersome. So now instead of that, I use 2 sets of needle, because once the needle is there, putting into the hole of the scleral fixated lens becomes easier. So I didn't want to really do very massive surgery. Actually, trying to remove the adhesion and all those things cause a lot more inflammation. If the iris is stuck somewhere, and then I found even if you remove it, it gets stuck again. So it's better to cut it if you want to, but such an old adhesion, there's no point of trying to cut it and trying to place it over there. So the one thought, can we place this lens, lifting the iris and put into the sulcus? But so much of a fibrosis, I don't think it is worth it. So the lens was scleral fixated. Thank you very much.
Thank you very much. And faculty would like to share their experience in such situation? All the friends in the hall, would you like to have any question for Dr. Lal? Sir,
only thing I will like to talk over
sir,
here, all those. Yeah.
No, please go ahead.
So only thing I will like to talk over here is that all of us should know IOL explant. Particularly nowadays we are using foldable IOLs, and if you are using multifocal IOLs, so sometimes patients may be very unhappy with the multifocal IOLs, and out of 100, 1 or 2 patients might be so unhappy that you need to remove it. So even I suggest all my residents, you put the lens inside the eye even without any problem, cut it and remove it, so that whenever you need it, you are confident that you can remove it. Because if you are not able to remove it and you feel jittery, then patient is on an offensive and you are on a defensive. So any patient is symptomatic, I tell them, you come, I'll remove it and put the next lens free of cost. So some of the patients could not adopt it. I had one patient which I removed after nearly 8 months of surgery. He tried to adopt it, could not. He had floaters, he was worried about that. Then he developed by the time ERM also. So with so many things happening, so we removed the lens, now he is comfortable. I had one patient who had the eye-hands lens implanted in one eye. He had minus 1.25 diopter of myopia. He had excellent vision, but he was not happy. I want to see at all distances. He actually researched everything, and then he compared VVT and synergy. Are we getting late?
No, please go ahead.
So I explanted. He went for the VVT in the one eye. Then he said, sir, iska vision intermediate is very good, but it is not as good as eye-hands had. Because eye-hands minus 1.25 was absolutely perfectly focused 1 year. So next eye, I said, I'll put you the synergy.
Good.
And if you are happy, you choose the lens. Now you got the experience of all 3. So you are happy with the synergy, I'll cut the VVT and put the synergy over there. If you are happy with the VVT, I'll cut this synergy and put the VVT over there, so you decide whatever you want. So after putting the synergy, he was very clear. He said, VVT is giving me clearer vision for distance than synergy, but synergy is very good for near. But with both eyes open, he was absolutely comfortable for near and distance both. So ultimately he was happy. He was very finicky type of patient. So if you have a confidence, or if you don't have a confidence in removal, then probably I would have not tried to do all these maneuvers that you tell the patient in advance that I'm putting this synergy. If you're not happy, I'll cut it and remove and put on a VVT. So you need to know how to explant the lens as well.
Sir, I know you are a man of wisdom, so I would like to ask you some non-ophthalmological, non-technical question, social question. Sir, in such situation, if the patient is operated by somebody else,
Operated by?
operated by somebody else, your colleague, not by you, sir, what will be your charges? I mean,
See,
how will you handle this
no,
part, financial part?
so far as my any colleague is in trouble, I got no interest in charging any fee from the patient, whosoever he may be.
Okay.
And I request my colleague to pay for the material. I will not bother the patient at all. If he comes for the second surgery to me for the IOL explant, and if the colleague has talked to me, then 100% it is done free of cost.
So
But
you
if he has
don't
not talked
yes,
to me,
respect to the
then
colleague.
it is entirely a different matter. Because patient was operated somewhere else, he comes to me, and then I explant it, then of course he is mentally prepared for the full fee. But if some colleague has referred to me, I always tell them, some of the colleagues talk to me, so you send to me, I'll take care of it if you have got any problem. Either by convincing or taking the bold step. But if the colleague has not talked to me, then it is entirely a different problem.
Thank you, sir. See, there's another point, Shail. What he said, that never use any word like mistake, this or that, when the case is operated by somebody else.
Never?
And now there is another point that you don't charge the patient. If the colleague has called you up for the further this thing, I mean, all friends, no, it is what we do, that we don't charge, make the most maximum. At times it has happened, no? If our colleague has collected the charges, he will tell that, sir, those charges which I have collected will give to you. But let us not charge the patient extra. So that colleague, whosoever is charged, that money is transferred to you. I mean, the second
Whether they
surgery.
transfer,
So
I think
these
this
things
is
are very
once
important.
in a year type of a situation, so I don't think that 10-20,000 rupees this way or that way or 10-15 minutes of your time really bothers us. So, but only thing, the decency and courtesy should be there. I mean, I had the doctors, patient has got, you put on the lens, patient has got 50 IOP for 1 week or 2 weeks, you are holding on to that patient, not referring anywhere, then patient comes to me. I call up myself, and then if you can handle, the patient needs explant, can you handle it?
Yes.
Kehta, yes. Then I go in, I ask him, he had put 2 IOL, they never informed me there's another IOL lying behind. I mean, so these type of colleagues are not welcome. I mean, when I'm giving a call, I'm trying to help you out, that I'm not criticizing in front of the patient. Then this has happened twice. Another also, one of my colleague had a epinuclear drop over there, and then I put in the lens, patient had a lot of problem, inflammation and not going. So I'm asking you, the lens is subluxated and you're not giving the right picture. So I mean, at least you tell me, sir, there is a drop over there. I mean, I'm giving you a call. You're not giving me a call even out of the courtesy, being senior. I mean, we are such a level where the last thing on the earth we like to criticize anybody.
So that's why
So
in
we
such
go out of the way and then you don't even respond and tell it correctly. That's not on.
So in such situation, you have to handle the patient both way, medically as well as socially. Please,
And,
Rajiv.
That in any case we do. I mean, that's
another
a senior
important-
doctor's responsibility that, and we have got to set the right train for our
Colleague,
coming
yes.
generation. So
Please,
never
Rajiv.
ever, never
And
ever.
once it is operated by somebody else, somewhere else, which doctor you don't know, sometimes you are in a critical situation. Once you are going to operate, it is a complicated situation. You have to explain the pros and cons.
Yes, that
and
is true.
At the same level, you don't want to criticize the earlier surgeon. It is something like that.
Yeah.
It is slightly, it's not in the place we are going to manage. But additional surgery has an additional risk.
Yeah. Thank you.
And sometimes when the colleagues, I mean, a lot of people have to learn. Once the patient was a post-LASIK patient, so she never wanted to put on a glasses. I suggested, okay, you can go for multifocal. And believe me, I put a lot of multifocal in post-LASIK patients. All of them are happy. I've not seen any patient cribbing about it because they are mentally tuned not to have the glasses at all. And then it goes to some doctor somewhere in the periphery of the UPSS. It's like a bomb, never get it done. I will never, it's a criminal. I mean, and why you have got to use such a strong language? Of course, I didn't put the multifocal in there. When she came back to me, I said, no, I'll put only monofocal. Because somebody has already poisoned your mind so much against the multifocal IOL, and anything goes wrong, then you will keep on saying that doctor has already told me, don't put it. So I said, I'm not going to put now multifocal in your eyes. So I think you should be very careful what you talk to the patient, not to actually, not to poison the patient's minds and not put on a suspicion on the integrity of the doctors in front
Yes,
of the
yes,
patient.
very true, sir. Sir, with your permission, we go to the next one, sir. We'll request Dr. Vineet Shah to cover his presentation, dislocated IOL in the vitreous, and how will you manage. Dr. Vineet Shah, please. He's a very good vitreoretinal surgeon in Surat.
Good morning, everyone. Thank you, Shroff sir, for giving me the presentation and the opportunity. So, when IOL is in the vitreous cavity, so there are no financial disclosures, despite all the precautions and other. Okay. So, despite all in planning the surgeries, we do see patients where the IOL is in the vitreous cavity, or the entire IOL back complex along with the CTR after a few years is in the vitreous cavity, and even AC IOLs been falling into the vitreous cavity have been seen. So IOL dislocation is reported, like sir said, 0.2 to 1.8% after routine cataract surgeries, and the causes, as I earlier mentioned, is optimal PCR support is not there, zonular dehiscence, pseudoexfoliation, trauma, or a Marfan syndrome. So the preoperative factors which we need to consider while taking up these patients for surgery is like initially we need to assess the patient. We have to see the patient. It is not like some doctor has referred and we directly take up the patient and see the patient in the OR. We need to assess the corneal status, any vitreous in the anterior chamber, whether there is a nucleus or any cortical fragment or IOL which has gone inside, any retinal problems are there, and then take up the patient for surgery. And the second thing is timing of the surgery. There is always a debate about primary as well as secondary intervention in a case of PCR without an IOL in the eye. So studies have shown both primary on the same day or secondary intervention which is done after 2 weeks, both have the same result as well as same amount of complications. So it is not a medical emergency, and we should not directly go in and start operating without assessing the patient properly. And the choice of IOL, as sir previously mentioned, we can use a sutured SFIOL, or the same IOL, we can suture it in the sulcus, or we can go for a sutureless SFIOLs. So my surgical plan always is a complete vitrectomy and explant the IOL, unless it is a 3-piece IOL which can be fixated. Usually I don't prefer monofocal IOLs to be sutured via pars plana routes. And a secondary IOL implantation which we need can be either iris fixated, a sulcus placed, or a scleral fixated IOL. So this will depend upon the surgeon's experience, patient's age, and other cofactors which are present at the time of surgery. So in this case, we can see there is anterior subluxation of the IOL. It's a toric monofocal IOL. And whenever we see such a picture, there is always a temptation that we'll go ahead and bring it out into the anterior chamber without doing a complete vitrectomy. But as you can see, we need to do a vitrectomy around the haptics. It is the haptics are nicely entangled into the vitreous. When we just pull it and fish it out from the anterior side without removing all the tractions, it is bound to occur. There will be vitreoretinal traction, and in future the patient might develop complications. So we need to free the lens completely. Once the lens is free, it will fall freely into the vitreous cavity. I place a PFCL bubble to prevent any macular injuries, and then we can bring the IOL into the anterior chamber and explant it via clear corneal or a sclerocorneal route. This is the second case where it is a pseudo-exfoliation with non-dilating pupil, and the entire IOL back complex along with the CTR has gone inside into the vitreous cavity. The case was operated around 7 to 8 years back, and later the patient had come with this complication. So the same principle, we need to do a good thorough vitrectomy and relieve all the traction surrounding the IOL back complex as well before pulling it out. As you can see, once the traction is removed, it will fall nicely inside. As we can see, entire CTR back complex is there. I made a clear corneal incision, sclerocorneal incision to remove it. But the other thing was that the entire anterior capsule was fused to the lens due to the fibrosis. And when we tried to lift it up just with suction, it was not coming up because CTR, lens, bag, everything, the weight is much more than the suction which can pull it up. I had to do a little vitrectomy and make an opening into the anterior capsule which was fused over the IOL, and then lifted it up with the forceps and brought into the anterior chamber, and then we can remove it. So once we do a complete vitrectomy and IOL explantation, nowadays we are confused by too many IOL options which are available. So like sir suggested, we can use the same lens, we can use scleral fixated, like sutured IOLs, iris claw lens, Yamanese technique or Gabel's technique, or glued IOLs, and now recently this CMT flex IOL has come, which we need to just exteriorize it and leave it. So too many options are available, and we can choose upon our convenience and our expertise which is suitable for us. So surgical principle which should be followed for all is it should be placed correctly into the ciliary sulcus. The haptics should be placed and fixed exactly 180 degrees apart to prevent astigmatism. And the corneal center as well as 0-180 degrees should be marked so that they are all in a straight line. So this is a video courtesy sir who prefers to suture the IOL which is already present inside, and the haptics which are the loop haptics with C shape, where there is a space between the two haptics, we can exteriorize those and suture it to the sclera. So what I prefer is the modified Geber's technique, where we do conjunctival peritomy after marking, do a light cautery at 0-180 degrees, make scleral tunnels 1.5 millimeter away from the limbus, and they are around 2 millimeters in length. Partial thickness scleral tunnels are made. We check the tunnel size and the thickness, partial thickness is good. Then we perform, this is a 25 gauge pars plana vitrectomy, and after completely doing the vitrectomy and removing the IOLs, we'll go for fixation of the IOLs. We enter with a 23 gauge needle at the site of the IOL implantation. Here the light pipe is acting as a scaffold to prevent the IOL from falling inside further. Now foldable 3-piece IOLs are also available, so we can go through a clear corneal incision if we can remove the earlier one with cutting, or if it is a foldable, we can remove it from the same suture side. So once the IOL is in the vitreous cavity, we hold the tip of the IOL and bring it out from the sclerotomy which we have made near the tunnel, and it is just fixated inside. We don't need to put any glue or any sutures for that. The same thing is repeated on the other side, and we can close the case. So the complications which we have noticed are sometimes there is disinsertion of a haptic which needs refixation, which can be done easily. Hypotony can occur, and this is transient due to unsutured sclerostomy sites. Once we patch it for 24 hours, the hypotony and everything also subsides. Rarely some vitreous hemorrhage due to oozing of blood can occur, which also clears within a week's time. And the rates for cystoid macular edema, retinal detachment, and hemorrhagic CDs are same as what we do for other surgeries. So in general, what I will advise is that we need to do a good vitrectomy. Don't pull it blindly. Even before, when we are trying to go for suturing, we need to do a good vitrectomy at the suture sites also, where we are exteriorizing the haptics, because there also the vitreous gets entangled. And once it is done, we can go for sutured or sutureless IOLs, whichever is comfortable. Thank you.
Thank you, Dr. Vineet Shah. Thank you. Now we go to the, yeah, sir, you can continue, but then I request Dr. Rajiv Chaudhary, please come over.
Pointer.
Thank you. Good, good. Anybody would like to share some comments?
What lens in cases of, Doctor, will you will personally prefer to put? Once your lens is down, you have removed.
Yes, sir. Foldable three-piece.
Mic.
No, once the lens is down, you have removed.
Yes,
the
sir.
lens. Thank you.
Loop out either the new implanted lens or the same lens and then fix it. So your maneuveration becomes so easy. I tell you, I finish within 15 minutes, 20 minutes. Because we don't, we avoid corneal maneuveration. This is my choice, my way. Rajiv.
Good morning, friends. Thanks, Dr. Shroff, for inviting me for excellent session. My topic is tips to avoid such situation during primary surgery. Friends, we can see some factor which may later on lead to the subluxation because sometimes the condition as jonular dialysis, earlier dialysis, or minimal dialysis, we miss it. We are good surgeon, we have performed and we have put the lens. But later on, pseudo-exfoliation, there are some factors. This can be early or late. Early, probably our surgical, some complication, late, some differences or some jonular weakness. This can lead to patient severe as per degree of dislocation. As it is reported, is 0.2 to 3% of patient after surgery has the dislocation and give the symptom like decreased vision, diplopia, glare, ocular plain, and everything depend on the extent of IOL shifting. Most cataract surgery preferred with no complication, IOL usually secured in the bag, but in high risk cases, chances of IOL dislocation are increased. These are previous history of trauma. It has not given the problem at the time of surgery, but jonules are weak and later on it can lead to the subluxation, pseudo-exfoliation, neuropathy. So evaluate all cases completely and discuss everything with the patient. It requires preoperative complete examination and you should take care of CCC diameter larger, chopping technique, so give to less trauma to the, in this delicate cases, less trauma to the nucleus or jonule and remove tangentially the cortex, so give less stress on the jonules. You can use the oil capture technique in weakened jonules, compromised PC or anterior capture of the optics, posterior capture of the optics. There are some of the situations you can avoid this decentration. Use of CTR in jonular weakness, suturing the CTR. Once you have put the CTR, it's CTR itself with the lens tilt. So you may need the suturing of the CTR. You have to select the IOL design, capsular contraction, single piece hydrophilic or three-piece hydrophobic. And sometimes you see the patient. This with the many times you come across. So if earlier you do the anterior capsulotomy with the YAG laser, you can prevent further dislocation and decentration in this type of cases. And OCT, anti-stomach imaging, this can detect preoperatively that you may going to end up in the problem. So it is a very helpful diagnostic tool for the posterior polar and sometimes a hypermature cataract, you may not be able to assess it properly. So it is one of the video where I assess the preoperatively, there is a large rent we try to do. So it is just to evaluate that what the situation, use the rexis, a relatively good size, but keeping that size that if you may have to put the lens on the sulcus, so it should be good. With a staining viscoelastic, cataract was soft, minimal hydro delineation, aspirating the cortex. We are aware that there is the rent. Just remove your cortical aspiration. Will first. Aspirating. Then you need the good vitrectomy, triamcinolone. It will help us to identify the vitreous stag and good anterior vitrectomy. Now, there is an option. Either you can put that lens in the sulcus 3-piece, and either you will want, if it is the putting this lens in the bag, because we find that support was good, identifying the posterior capsule well and keeping that center. So it's taking due care. You can put that lens, you can put this, you can do the anterior capture of the optic. Then in cases of jonular dialysis, it is, you should suture that CTR well. Putting that CTR help us to stabilize. Then another important thing, that we are having the good surgery. It is just many times we are using the injector and it's go with the jerk. It is, in this case, it is created the hyphema, but many times if you go in the bag and it can rupture the bag, and your all case good surgery is turned into the bad one. Then you may end up the break up the lens if you have not done proper assessment, the injected lens. So you, as mentioned, you can see that all this lens is completely broken. So sometimes, because it is so large, the lens, but sometimes small pieces or small haptics are broken, which is not go unnoticed, and later on it can lead to the degeneration. So you should be aware how to remove it. Cut that lens and remove it. Then you should be well aware with the iris claw lens. It is the safest surgical. It is the case with the subluxated cataract. But then if you will end up with the PCR and you're not able to, capsular support is not good, this iris claw is a very good option. You should be aware that you just hold it from this junction, and will prefer using iris claw instead of glued IOL or sclerofixated IOL, because it is so simple.
Good.
Many times we are coming with the lens total bag, as Dr. Shah mentioned, that total dislocation. This is the case because nowadays there are cases coming which have total, you are good placed very well lens in the bag, but your journal support is very bad, and the lens is dislocated with the full bag. So you here you should have the preoperative evaluation very well, that you can do the good vitrectomy and place the lens. Again the iris claw, and in this also, if you should be capture it well, because otherwise it can also dislocate. So you should assess that inclination should be good, and this type of the lenses will help you in security. Holding this at this junction will help. Then this repositioning, because that support was good. Capturing, because this 3-piece lens was in the anterior chamber, and so just dialing it properly, it will give it. So assessing your lenses after completing the surgery, its location will help. And this is one what I was just saying. This is the case that you come. This is the recently come at the case. One lens is dropped and another is showing. There is some problem. Already someone has done the capsulotomy, but still the lens is moving. There is a good vision and other. So this needs a handling. So in short, identify high risk prior to surgery, planning and plotting as per condition. Intraoperative careful steps should be taken, can avoid IOL dislocation. Thank you, sir.
Thank you very much. Thank you all faculties and friends. Thank you very much.
Okay, thank you.